All right. Hi, my name is Peter. I'm an emergency physician resident working in Stockholm, originally from Denmark. Um, this is a lecture I usually give at the Emergency Medicine Core Competences course. And this is my version of it. There's a different version of it as well. But I've modified it a little bit to my own liking. It's very much like my 5-hour lecture on neurology. So if you already watched that, there won't be that much new stuff here, maybe 10 or 15% new stuff. But there's a lot of stuff in the 5-hour lecture that I have not put into this. Because I'm trying to make this one short or shorter. So I hope to keep this at least below an hour of playtime. All right. This is kind of the essentials. Trying to boil it a bit down and do it in a shorter time. So the first part, I'm going to talk about a bit of like pearls and concepts, and in the second part, I'll go through some neuroanatomy. So neuroanatomy is extremely important in neurology, right? And what we are, I usually watch like this. So it's like a bottomless pit of neuroanatomy. Like there's always more neuroanatomy to be known. But what I think that for most emergency physicians, we actually only need the basics and a bit more to be able to make like 90% of our decisions. It's like the Pareto principle, but in the we rarely need this kind of knowledge down here. That's why I made it a triangle. So this is you can get most of it by just being here, and then like the deeper you go, the less you will get. There is a law of diminishing returns. But neurologists needs to know this, right? Because sometimes you do need this knowledge. That's why we consult them. So I will try to teach you some of these mental models and these basics so that you can make your decisions and assess the neurological patients, and sometimes also consult neurology when you need some more special knowledge. Okay. So the concept that I wanted to teach, and a lot of the books in neurology and emergency neurology wants to teach, is this concept of where is the lesion, what is the lesion, and these two concepts, when it attains to like as it attains to the OPQRS principles, it's usually where is the lesion has something to do with the position or the pattern of how the patient is presenting, whereas the what is the lesion, like is it a stroke, like a vascular event, is it a neuroinflammatory event, and so on and so forth. Has more to do with the onset, the quality, and the timing. And these two together can sometimes be called hardware problems, as we'll see in a little while. Hardware problems is if you think of the nervous system as a circuit or a neural, like a electrical wiring circuit, then the beautiful thing about neurology is that it's like a 1-to-1 ratio. Like if you get a lesion here, then you will have a certain pattern. Sometimes these patterns are not totally like, yes, there is one lesion here, but sometimes the pattern that you will get needs to be teased out or teased apart from other conditions that looks like it, and sometimes you need some special tests to do that, but you will always, like almost always, be able to tease out where the lesion is. Right. So that's an important concept that I'll get to, like that 1-to-1 ratio. Okay, then I usually want to also talk about is there a lesion, because is there a lesion is because there's a lot of mimics and there's a lot of non-neurological problems. We usually call these software problems. Like it's nothing to do with the wiring. There's no lesion in the wiring, but either it's a mimic, like a medical mimic, like if you have hypokalemia and you get weakness from that, or you get PMR and you get weakness from that, or it's a software problem where it's more like the wiring is there, but it's not being utilized in a good way, and that's often an explanation of how we develop from somatization problems to functional neurological deficits, where you have your patient who has functional neurological deficits from a non-hardwire, where there is no lesion. And as we'll talk about in a little while, the way we pick up these is knowing about the neuroanatomy, the 1-to-1 ratio kind of thing, and seeing that the way that these patients are presenting does not fit the neuroanatomy model. And the problem is that sometimes these symptoms are quite vague, and we need to know a lot about the neuroanatomy to actually be able to tease these out. But oftentimes they're quite obvious, and we don't necessarily need to tease them out with difficult tests. I won't talk any more about this in this lecture, but I've talked plenty about the functional neurological deficits in another lecture, because I think it's really important, and it's a lot in the, a big part of neurology is not and medicine is not hurting your patients by the test that you do. And a classical way of hurting your patients is by doing a lot of things to someone who actually has a subconscious functional neurological problem, which is like maybe 40 or 50% sometimes in the neurological outpatient clinics, as I believe, or at least quite a big number. Okay. So when we have a patient presentation, once we've gathered where's the lesion, what is the lesion, then we have some kind of hypotheses, right, from the history, and then we want to confirm our hypothesis through testing. Like, we want to tease apart the similar syndromes, and that's, so it's like a 3-step process. Where's the lesion? What is the lesion? Is there a lesion? And can I confirm my hypothesis by exam and testing? This kind of approach is really good for especially like motor deficits or sensory deficits. It can be used for certain other presentations as well, but for some of the main presentations in emergency neurology, this is not the best way, or this can only partly be used. I'm talking about headaches, and in the appendix to this lecture, I'll talk about shortly. I'll talk about this approach I have to these. Dizziness also has its own approach, and seizures has its own approach. Though you can try to, like in dizziness and seizures, you can try to like guess at where the lesion is, but it's not as useful as it is in neuromotor deficits or sensimotor deficits. Okay, so let's go through this. Where is the lesion? So we already talked about there's this 1-to-1 ratio, and that's like the ground layer for why we can say that if a patient presents in a specific way, then this must correlate to a place in the brain. And it's really important that we try to make this correlation, because sometimes if you just do a scan, then you will find a lot of spots in the brain with certain patients, but you need to know which spot is actually correlating to this specific symptom. The other thing I wanted to say is, I'll get to that in the next slide. Sorry. Yeah. All right. So, and we already talked about, if there's not a 1-to-1 ratio, then we have to consider that it might be a functional neurological problem, like if it doesn't fit with the neuroanatomy, the anatomical gestalt, and it doesn't fit with the tests that we're doing, then we should think about, well, this might be a functional neurological deficit. But it's a double-edged sword, because if you're not comfortable with your neurological examination, then sometimes you may think that it is not according to neuroanatomy when it actually is, or you may not be comfortable enough to ruling it out. So that's why it's almost always a good idea to do thorough testing with MRIs before saying something is functional. But it's really important to actually have it on your differential and talking with the patients about this. And it's important to not stigmatize. These patients don't know that they have this thing. They don't do it consciously. It's something that we can all end up doing from time to time, because somatization is usually the core thing in it, and we all somaticize in some way. Okay. Then the other concept of where a lesion is, we should still think probabilistically, because if you take a presentation like a drop foot. You have a patient who has a drop foot. That's what the chart says. Well, then even though I say it's a one-to-one lesion, then you have to tease it out before we can actually say which part of the brain is actually, or the nervous system is actually the culprit lesion. And that's where the probabilistic thinking comes in, because before we do our testing, we could think that, well, a drop foot, that's usually a peroneal nerve lesion. That's quite probable. Then it could be cauda equina syndrome as well, or a L5 lesion. It could also be a homunculus stroke, if it depends on how the foot is working, right? And it could also be where is the lesion, or sorry, there is no lesion. Like it could be an Achilles rupture, could be an acute ischemic embolus, depending on the context. And you may, before going into your patient presentation, before asking the patient anything, you might do these, like, how likely are these things? And for a drop foot, like if it was a homunculus stroke, well, then I would expect, like, if I should confirm this hypothesis, then I would expect that in no direction would the foot be able to move. Whereas in these, as we'll shortly talk about here, it might be that you would test eversion and inversion and see that the foot has different patterns of inversion, eversion power, and then you can discern these two. And this is usually quite easy to rule out, because you have Thompson's test and other obvious signs. It's usually only like when you're stepping on tiptoes that you can't do that. And then ischemic embolus, usually there's other signs with that, right? Pain, pain. All right, but just when you see the chart, you have to think about, this could be the entire nervous system, and it's so think probabilistically. Even though there's one-to-one lesion kind of way, then it is not totally clear yet. It's still like a silhouette. We need to, by examination, make it clear which one it is. Okay. And then we have these patterns. I think it's really important to know about these patterns. So if you have a contralateral lesion, like you have the one side of your body is being affected by either motor deficits or sensory motor deficits, then you could think, oh, well, it's a central lesion in the somewhere in the brain, and usually the pattern would either be arm, face, or arm, leg. And depending on the level, you might like look at this from three ways. There's like the pattern of homunculus stroke, where it's only like a functional unit, like the thumb or the hand or the foot, that is being affected in all directions. It may be a cortical stroke, where you have what you might call VAN, like vision, aphasia, and on the left and on the right neglect. And then you might have subcortical strokes, which would be the sensimotor deficits usually. So this is just a way of, like, if you have the combination of cortical and subcortical stroke symptoms, then it's a big lesion, right? And in some studies, that is called the VAN score, and you have to think of embolectomy. All right. So and with all of these, this is like the basic pattern that we need to know, but you can always go deeper. You can always, like, I could say that, well, how the neuroanatomy is, or subcortical strokes, like what kind of brain areas are, like, just as I said, with like contralateral, that's the basic gestalt. But if you look into the different brain areas, then you have, well, face, arm for anterior strokes, and so you have different stroke syndromes, and you can always, like, the different stroke syndromes can also be broken down. So this is like the bottomless pit I'm trying to illustrate here, and we're in the top and the middle here by just knowing these, and these are usually the only ones that we need to know. All right. Then we have the brainstem strokes and the brainstem lesions, because we don't know whether it's a stroke yet. That's what's the lesion. So here we have a so what is like the pattern here is it's crossed lesions. So face, On the ipsilateral side, and on the contralateral side is that's the body symptoms, right? So, and there's two syndromes from the if you check Life in the Fast Lane, then you will see an article about the rule of 4. And then there's the lateral syndromes, which are harder to pick up usually, because they usually have sensory symptoms more so than the medial syndromes, which usually have more distinct motor deficits. I won't go through the rule of 4 here, but you can read on it on Life on the Fast Lane and the Gates article, the original article there, or check out my other video. Then you have your medullary syndromes, and your medullary syndromes is we'll go deeper with these in a little bit, but just right now you'll see that they usually have a triad of urinary or anal problems, sensory level, a sensory level, meaning like on their stomach or higher up. They have like a sensory deficits. That's usually a quite significant symptom if they say they can't feel on either one side or both sides of their stomach or higher up. And then you have usually tetra or para symptoms, motor or pain symptom, painless or vibrationless, like they can't feel the tracks going down or have been hurt in a specific way. So para would be both feet, both legs, and tetra would be all 4 limbs, right? That's usually how these presents. Then you have your poly and mono neuropathies. And your plexopathies, which are further up. So your plexopathies usually don't follow a dermatome. They're usually a bit more complex. But the other ones usually follow a dermatome. And they usually have these, if it's a mono, then it's usually, like, depending on how proximal it is, it will fit a entire root, or it will fit a peripheral nerve depending on how high up it is, how proximal or distal it is. Usually it is usually both derma and motor if it's like a lesion, but if it's cut over, but if it's from multineuritis, the multiplex, or if it's from polyneuropathy or mononeuropathy from other causes, like it could be carpal tunnel syndrome, that is usually then it might be only sensory, right, or only motor sometimes as well. Then you have polyneuropathies, and the usual polyneuropathy pattern is this: like you have distal feet and sometimes hands involvement, but not proximal, not to begin with anyway. And we all know the Guillain-Barré syndrome, where it's like, or the AIDP, which like acute inflammatory demyelination polyneuropathy, and these conditions are usually like it's a spectrum of disease, but the most common is the Guillain-Barré syndrome, where you have it moving up, and it's actually a radiculopathy, not a polyneuropathy, and that's why it's possible to actually do a lumbar puncture and see that there's stuff in the there's protein in the lumbar cord around in the central canal, right? All right, but and then you have the plexopathies that it's like an area that is not, and this is where sometimes the neuroanatomy can go a bit weird and become a problem for people, because you may say, oh, it doesn't fit with a specific neuroanatomical area. Well, that's true oftentimes with these, but the problem is that it can still be a lesion if it's a plexopathy. But usually plexopathies usually they're traumatic, but they can be otherwise non-traumatic sometimes. So, but usually they have quite a easy context giving it away. Then we have in the last bit here, we have proximal weakness, usually either fatigable or non-fatigable, depends. But if it's fatigable and if they rest, then it becomes better. Especially if there is the eyes or is Bulbar symptoms, then it's more likely to be neuromuscular junction disease, such as myasthenia gravis or Eden-Lambert, or I think botulism as well. But if it's the proximal muscles and it's not that fatigable, that's usually a myopathy, and which can be both for medical causes or genetic usually causes. Okay, so this is one of the we're still on Wearer's deletion, and this is one of the most important slides, Larry. Just print this into your memory. All right, and then another one of the last concepts is that you have something called the you have ovimotor neuron syndrome and lower motor neuron syndrome. Lower motor neuron syndrome was the ones on the previous slides that were read, and so after sometimes after around a couple of hours, from hours to days from when you get the lesion, you will see patient developing if it's a first neuron problem, meaning from the brain and down to the down to where it just before it goes out into the anterior horn. Then it becomes then you'll have a ovimotor neuron syndrome, such as a stroke, where you'll see spasticity when you test for tone, and from reflexes you'll see hyperreflexia, and you'll have a Babinski's positive test, and you'll see other signs as well, like Hoffman's test sometimes, depending on the reason why. So these may be more or less developed depending on so much. All right, but you'll usually find one of these. In the lower motor neuron syndrome, you will have the opposite almost. You will have a decreased tone instead of spasticity. You will have hyporeflexia or areflexia, and you'll have no Babinski's. So these are important, especially if the patient presents after a couple of days, because then you can usually discern whether it's a central or a peripheral. If it's acute, then it's oftentimes harder. In certain syndromes like seizures, you will temporarily get like a Babinski's positive. So there are certain exceptions to the rule, but usually it takes hours to days before these develops. Yeah. All right, and the last one concept here in the Wearer's deletion is the concept of recrudescence. It's a concept that also exists in other areas, such as endocrinology, kind of, because it like kind of triggers if there's something that if you had a lesion before and then you get an infection or you get warm or some other metabolic disturbances, then sometimes you will get your symptoms back. And we see in strokes where if you had a stroke like with a right-sided lesion, then it became better over time. But then you get an infection, and you may be a bit weak, like or haven't been drinking, or you come in with sepsis, something like that. Then you will see that that side becomes weak again. But it's not allowed to become weaker than it was at its worst. If it becomes weaker, then you have to consider that it's a new lesion. But if it's within the range that it's always been, then it's usually it is many times often a stroke recrudescence. We also have to think of how likely is it that you get a new stroke in the exact same location from all the from all the places where the vessels could shut down or be embolized from. That's quite unlikely when you think of it. So if they have the exact same distribution of symptoms, but they have been rehabilitated, but now they're weaker again, and it's oftentimes a recrudescence thing if they have fever or other metabolic disturbances. And one of the classic ones is the pseudo attacks or the Uthoff's phenomenon in MS. All right, so that was Wearer's deletion. Now we move on to when we kind of have a hypothesis of where the lesion is, then we can try to guess also what is the lesion, and we'll try to pick apart from the history what elements are important to get at what is the lesion. Like, is it a vascular event? Is it a inflammatory event? And so on and so forth. So here are some and Eric Driver usually likes this 5M3P. If you have a stroke then you should always think of, could it be mimics? I always think that there's maybe something lacking from this. One of the things that I really don't want to miss is what you would call like embolic strokes from an endocarditis, for instance. That's a mimic. And if you trombolize that, you will you could die, right? So it is a actual stroke, but it's one that shouldn't be treated as a stroke, a vascular stroke. So, all right, but getting on with what is the lesion. So one of the important things is the onset. That's probably the most important thing. So if something is vascular, and then usually something that is in this area here, it's something that presents really within seconds. Or like the caveat here is that oftentimes a lot of things are gradually developing, and then suddenly like the drop of water that, or the grain that like the breaks that camel's back, makes the patient suddenly get the symptom. So it might have been subclinical before, but that now that suddenly it has tipped over and become like clinically relevant. We do see that sometimes with tumors. They haven't had any headaches, but suddenly they get a seizure. So it's kind of so you can't always really. It's just one data point, right? And you can't always rely on this was sudden, and therefore it must be vascular. Other times it's also like suddenly discovered. So the patient may find themselves in a situation where they don't need a feature of their body, but suddenly when they are in a situation, they would suddenly feel it. Like if they're out walking, or they've been sitting all day with crossed legs, and then they're maybe feeling a bit weak, maybe in their feet. They think it's subclinical. They don't really realize that they're weak in their foot, but then they walk in the sand, where when you really like need to be able to use it, and then they think like, oh, it came suddenly when I walked in the sand, but actually it began before. So sometimes it's hard to discern the onset, and that's why, which I won't get into here, the way of questioning your patients is really important. How to not lead the victim. I've talked about this in another lecture about communication and headache and probabilism, so please check that out if you want to. In this area, it's usually like if it's days to weeks, then it's usually more like inflammation, and this is the area where you can use your upper motor neuron, lower motor neuron syndrome discerning patterns, and then you have like genetic stuff over here. Then you have the timing. Again, it's kind of the same thing as before. Like if it's something is with something vascular, you'll usually think that it develops right away, just everything at once. Whereas more epileptic, maybe sometimes migrainous or inflammatory developed symptoms would develop like in succession, either over minutes, hours, or days. It depends, right? And again, this is just a data point. I'm not saying that there couldn't be a stroke that develops like this, especially if you have multiple emboli, but usually it wouldn't be as gradually, or like that would be entire arm here, the entire leg here, and usually that's a specific pattern. But in general, this is thought as migrainous or epileptic or something else in nature than this, which is more vascular-like. And these are data points with likelihood ratios attached to them, right? So, all right, and then the quality of the symptoms. Sometimes symptoms are positive, or sometimes some symptoms are negative. And the classical example would be positive symptoms is like a gain of function, or not like your arm isn't weak, it's moving. It's moving in a way that you cannot control, like or you're having spasms, or you're having some kind of dystonia or something like that, right? That's a positive symptom. That's usually less likely to be stroke. There are strokes that can give you like hemibolism, like or choreiformic dancing kind of movements, or limb shaking TIAs. So there definitely are positive symptoms sometimes, but positive symptoms are more likely to be maybe migraine, seizures, tumors, and so on. whereas negative symptoms are more likely to be strokes, like a loss of function, where you suddenly lose your sight. Okay, so those were the worst lesion, worst lesion, and after that, you'll kind of have a hypothesis. Also remember, my third one, there is no lesion. Also had that in the back of your mind, and then you move on to can I confirm my hypothesis, and you do that through your examination. So your neurological examination depends on which patient you're seeing, right? So if you don't have a lot of, if you have a good history, and you can talk with your patient, then usually you can do a more focused neurological examination. There's a basic neurological examination that you should do, and I think in this lecture we're going to present the Swism way of doing it, and I'm not in totally agreement with that, but I think it's a good way of kind of cutting back to the bare essentials of what you actually need. And usually it will be like some kind of cognitive function, some kind of cranial nerve assessment. You'll need motor and sensory assessment, and then a coordination and gait assessment. Like that's usually like the 6 points assessment, and then you can and that you can, and then when you've done some kind of screening, and you can go into special tests if you need to, like Dix-Hallpike for BBPV. So these are your more hypothesis driven, where you might do the screening, but you quite quickly go on to really doing focusing on the tests that makes rule in or rule out. That is in opposition to where you really need just a decent screening, where you do pick the most sensitive tests, and then try to pick up on if there's anything. Then that might be your patient who's unconscious, or your older patient that doesn't give a good history because they're demented or something like that. Then you'll do your screening, and if you do find something with a high signal, then you'll use it, go from there. When we are talking about the neurological examination, I feel like it's good to just mention that there's a formal and there's an informal. And the formal is the one that we teach in books, right? But the informal is just as important. And my favorite example is usually when you have a facial palsy. The most important test is actually seeing their eyes, looking into their eyes while you're speaking, because when you're looking into their eyes, then you'll realize that if they're blinking less on the affected side than the non-affected side, then it's usually it's almost always a peripheral facial palsy. And not a central one. And I know you will often think but wrinkling their forehead is the classic test. Yes, but that test is not reliable in the early stages of facial palsies. So your peripheral palsy in the early stages will usually be able to wrinkle their head, or if it's mild, it will be really subtle. So looking at their eyes is a much better test. Okay. Then you have, as we said, your screening or your hypothesis-driven neurological exam, and your special tests. And usually when I teach this, I try to you do your pretest probability assessment with your history and where is the lesion, what is the lesion, kind of analysis, and then your next, I usually choose 3 tests that are really important for this patient. And because as default, you will always do your normal screening test in neurology, but which ones are the best and the most important? That's important to think about. As a way of practicing. All right, so moving on to the second part of this lecture, which is, can I confirm my hypothesis? How do I do this neurological examination? And I'll sprinkle in some of the neuroanatomy that is important. So, all right, so we're moving into some of these mental models and a bit more of the neuroanatomy. So this is a Swism model. They will only test for cranial nerves, what Eric Driver called clouds, which is motor function, proximal distal in the arms, and proximal distal in the legs, and then coordination. And I would argue that sensory information and cognitive information is really important here as well. And I would argue that you need the formal and the informal as well. But I think it's a good way of kind of getting down to the bare essentials of what you need in a neural screen. Yeah. All right. So let's go to the cortical findings, right? So when you because the first column here was cranial nerves, where you might find the VAN symptoms, the cortical findings, like visual, aphasia, neglect. Like there's lots of other cortical findings, lots and lots. Like this is where neurology often gets really exciting. And there are written entire books by Oliver Sackett or others in neurology, like because this is like what makes us human. Like the latest developed area of the brain is the cortex, right? So evolutionary wise, so this is where we have all of our human special functions, and sometimes if we get a hole in one of these cortical areas, it might, like if it's a big hole, it'll be one of these things, but if it's a smaller hole, sometimes it's really subtle, and you can have stuff like if you read the neurological books, then these are the where you get all of these oftentimes some of these peculiar syndromes. Okay, but for us emergency physicians, these are the ones that we are looking for. I would add that if you have frontal symptoms, you may see some things like perseverance or sometimes bizarre behavior, but that's which is distinctly different from like just delirium. But yeah, cortical findings. So if you move on to anopsia, which is one of the cortical findings, then you have this anopsia, which would be like before, like in front of the chiasma, from the eyes to the chiasma, you have some kind of lesion, or in the eye, right? Because it's monocular and it's total. That might be MS. That might be an ocular, like amaurosis fugax, something like that. It might be temporal otoritis. Yeah. And you have these are chiasmal. It's just in the chiasma, like the David and Goliath syndrome. And then you have these, and these are usually thought of as so like left side of brain controls the right side of the body, and in the same way with the vision. So if you have a lesion over here, like if it's dark over on the right side, then it's because there's a lesion on the left side, and if there's a lesion up here, like pie in the sky lesion, then it's because there's a lesion on the left side and below, right? It's kind of like inversed like that. Yeah, and it's behind the chiasma, right? And then behind the chiasma, then it becomes like binocular. Before the chiasma, it's monocular, and it's really important to, when you have eye symptoms, to discern is it monocular or binocular. Also, if it's diplopia, like double vision, then it's really important to discern those things. Also, it's important with diplopia to discern whether or not it's in all directions or not, right? But I won't mention anything else about diplopia. Please check my other lecture for that. All right, so neglect. Neglect is a favorization of the one side instead of the other. If you have really severe neglect, you will see that the patient is looking towards the lesion oftentimes. So if you have a stroke on the right side, they will look towards the lesion on the right side, but like kind of favoring that side. But if it's more subtle, which is often the case, then you'll have if you have sensimotor, sensorineural neglect, then you will feel on this side. You can feel this, yes. You can feel this, yes. But if I bimanually palpate you, then you will not be able to feel your left side because you're favoring this side. That's what is neglect, as opposed to sensimotor deficit, where you would not be able to feel this side either. If I just touch here, I can't feel this, but I can feel this, right? And you have sensimotor neglect, and you have visual neglect, right? So you have to do bilateral stimulation to get this tease it out. All right, then you have the other VAN symptom here, dysphagia or dysarthria. Dysphagia is important. Like they do sound like each other, but aphasia or dysphagia is a problem on the left side of the brain with either Wernicke's area or Broca's area, depending on whether you can speak fluently or not. For details, please check my other lecture. But it's about like the way we produce and like interpret words. Going down to your cerebellum, where you can also have cerebella. Not dysphagia. These are only on this area, in these areas, and then you go on to dysarthria because this like circuit here goes over to your motor cortex, and from the motor cortex and down all the way to your mouth. That's where you can produce dysarthria, where there's nothing wrong with your understanding or your way of developing your speech. But it's more like a motor thing. Either you cannot, if you have spastic dysarthria, it's up here. You can have cerebellar dysarthria, where you have talk like a robot, like in the staccato, you talk like this, or you can have like with your if you have been on too many benzodiazepines, then your muscle movements on your mouth is not that good. Or you can have facial palsy. That's the peripheral dysarthria or the flaccid dysarthria, right? So that's the difference between dysarthria and dysphagia. Dysarthria, you can know what you're going to say and you can say that, but it just sounds weird. Either because of a central lesion or a peripheral lesion. But dysphagia is something totally different. You can either not produce words, that's Broca's, or you will speak fluently, but you won't understand them. That's Wernicke's. All right. Then you have another thing here, which is not a cortical syndrome, but it's a ANS, a autonomic nervous system thing. That's unilateral meiosis and myeltosis, and that's a Horner syndrome. And that's important because Horner's U, especially with headache patients or neck pain patients, you have this U going from up here, the ANS going over here and then down here and to the carotid and then out to the eye. And there's four areas where it's really important to check for Horner syndrome if you're suspecting these things, or if you have a Horner syndrome, you have to think of these four things. Bear in mind that meiosis, or anisocoria, like different pupil size, is really common. Like maybe 20% of the population has this somewhat. And a lot of patients have a bit of lack of thalamus, especially as you age. So it's really important to see a picture from before with the patient. I usually ask them to show a selfie from before. All right. But if the most the common area that you think of is vessels, carotid vessels, or the vertebral can sometimes also develop Horner's. Then so if you have the correct dissection, I think it's like 50% will develop Horner's. Then you have your upper nerve, like the nerves in the upper part of your lower part of your neck. I think it's called ganglion stellata. If you have a Pancoast tumor and you have weakness in your arm, then you might develop Horner's as well. All right. Then you have your upper medullary area, where if you have a high cervical medullary lesion, then you might get a Horner syndrome. And then you have your last one, which would be your brainstem. And that could be from vertebral artery dissection, or it could be from a lateral stroke syndrome, such as Wallenberg's syndrome. So these are the first foremost, and Horner syndrome is something that you need to test for. Then you have nystagmus, and the nystagmus comes in different shapes and forms, and you can do a complete lecture on nystagmus. But I'll just say that there are spontaneous nystagmuses, and there is provoked nystagmuses. And the spontaneous nystagmuses are much more these are the ones that we need to be aware of, where stuff like what we teach in books, like if you have spontaneous nystagmus pointing upwards, like vertical nystagmus, then that is pathological, right? If you have spontaneous nystagmus rotating, then that's also pathological, either from the brainstem or cerebellum. And you have spontaneous nystagmus, especially like moving, like in different, like moving, like when you look to the right, and then it goes to the right, and when it moves to the left, then it goes to the left. These things are pathological for brainstem lesions or central lesions. But then you also have, like, all of these things can occur, maybe except the last one, but these things like the vertical nystagmus and the rotary nystagmus is really common, and it's like pathognomonic for posterior canal BPPV, as you will see Peter Johns has advocated for a long time in his YouTube videos. So please check those out if you want to know more about this. So before testing nystagmus, my take home is just let the patient sit for 5 minutes, especially if they're dizzy, with their head still. Either you hold their head or while you're talking to them, or you'll instruct them to hold their head still, because then you'll be able to tease out whether or not this is a spontaneous or a provoked, because the provoked will then stop beating once you kept their head still for 5 or 10 minutes, almost all of them. Yeah. All right, then you have conjugated gaze deviations, and here we're talking about usually like global or hemiglobal problems with the brain, like big lesions or epileptic seizures, right? So if you look towards your lesion, and like you're weak in the left arm, but you're looking to the right, then you're looking towards your lesion. Then you have a big usually stroke up here. That was the neglect thing I talked about before. Then you have this arm here going like that, and on looking to the left, and usually that's because this part of the brain is ceasing, and you're usually looking away from your ceasing area, and sometimes you will have this thing going on where you kind of have when they stop ceasing, they only have eye movements, but they're looking at the other direction. But you still have a weak arm, so you have a weak arm looking at the left direction. How does that fit? Well, sometimes that's because sometimes patients will have a non-convulsive seizure and looking to the other side, right? So when you give them like some kind of benzodiazepine or stop the seizure, then they'll stop looking to the left, and sometimes they'll then look to the right side. I've had a couple of patients doing that, so you can have a mix of these two. These are the most common, and then there's the one that breaks the rule, like you always look towards your big stroke. Well, if you have a brainstem stroke, it's the opposite. Then you'll look away from your big stroke if it's a pontine one. Okay, isolated facial palsies. Now we're moving away from the so this I already talked about this. Like contralateral forebrain is usually if you're spared your forehead, but that's usually for peripheral. Sometimes they do have a sparing of their forehead, or it's really mild and it's hard to discern. I encourage you to look at their eyes instead, or as well while they're speaking with you. All right, and then we go to the motor test. So the motor test, if there's isolated weakness, then it's usually like the discerning what is this central, or is this peripheral, and especially is it the forebrain or is it peripheral? Because if it's medulla, then medulla spinalis, the spinal cord, then it's usually, like, as we talked about, then it's usually parasymptoms, like both legs and arms or both legs and arms are involved. All right, so how can we discern these things? Well, one way of doing it is if you have a hand that is weak. If it's only weak in one direction but not the others, then it's oftentimes a peripheral lesion. But if it's weak in all directions at once, then there's no one nerve that can do that. And if they, unless they're cut all their nerves to that area, then it's a homunculus stroke. All right. So, but here's a few mnemonics to how to know how to test for neurovascular status in your arms and legs. And there's lots of like these diagrams where with and entire books about like the myotomes and the dermatomes, and I do use these and I have to like look up these all the time. But for screening of your patients, and I would give you these rules for the arms and legs that are much easier. So for the myotomes of the hand, just make them do an OK sign. The wrist is your radial nerve, if you can extend the wrist. If they can spread their fingers, then that's the ulnar. And if they can do the OK sign, or the British tea drinking movement, that's the medial nerve, right? Then the myotomes of the legs is like the ones that you need. Usually is the L5. Well, if you walk on your heels, then you look kind of like an L. And if the S1, well, if you go on your toes, then you kind of look like an S. And then you can look at this yourself, but this is for the drop foot. It's all about the eversion and inversion of your foot, whether or not it's a high lesion or a low lesion. And then you have your sensory in your hands, the dermatomes of your hands. Then you all know these like diagrams where you can have half the finger and importantly, there's certain areas that are really highly specific and sensitive that you can touch, which would be like the median part. Like for the median nerve, it would be the palmar side, of the second digit here. For ulnar, it would be the palmar side of the little finger, the tip there. And for the radial, it would be here the web between the first and the second finger. If you can touch here, here, and here, and they can do the OK sign, then they are cleared for distal neurological deficits. If they do have some deficit, then you have to go into a more specific testing, and sometimes with 2-point discrimination, depending on if it's an orthopedic surgeon patient, then usually they want that. All right. If you're moving up along the arm, then the technique to remember these is like the middle finger and your second finger is your that's C7, and then you have 2 on each side of the arm. So C7, that would be, and then it's like 6 and 5, and here is like 8 and TH1. All right, so 7 and then 1, 2, and then 7, 1, 2, and you count down here and you count up here. All right. And then the last one I heard recently, I think it was genius, because usually you have these oblique kind of really twisting motions of the dermatomes on the leg, and if you stand forward, then they will straighten out, but that doesn't really help us that much. But what does help, I think, is looking at it like this. So if you test here is L3 on the medial side of your leg, here's L4 on the, if you go to the knee, and then on the medial side of the knee, that's L3. On the patella, that's L4, and on the lateral side, that's L5. And if you want to test for S1, then it's the pinky. Okay, that's a screening, quick and no problem. And then the reflexes. Then you have reflex man here. It's there's this rhyme that goes with it. Like if you look at a person upside down, then you'll have 1, 2, tie your shoe. That's the Achilles, because you tie your shoe with your and you like dorsiflex your foot. Or 3, 4, kick the door. That would be like moving your knee to kick. And 6, 5, 6, pick up sticks. That would be your biceps. And then 7, 8, close the gate. That would be with your triceps, right? So that's how you could think of these. That's what's mono weakness. Then you have multifocal weakness, right? Where there's more than just one body part. Usually arm and leg, or both sides, and so on and so forth. And we already went through in the beginning this, so I will just skip it a bit, or move a bit quicker over it. But in general, we talked about these patterns. Really important to know the general patterns, because once you've done your examination, or once you've done your history, you get one of these patterns with sensimotor deficits. All right, and then you have your upper and lower motor neuron syndromes. Let's move on and just a little bit of more details, like a bit further down the bottomless pit of neuroanatomy in some of these cases. I won't go too far. If you want to go further, please check out my 5-hour video. But this, I think, is important. So you have your homunculus out here in your both your sensory and your motor lies beside each other. And you can see like the nerves are quite spread here, but certain areas are really big. So your entire foot is a big area compared to a small like brain area, and your thumb is also a big area compared to so you can get an entire stroke in your hitting your thumb, but you wouldn't be able to have an entire stroke just hitting a small point of your back. It would be much more than that, right? But it's like an area that is big in the homunculus, like your thumb, which you use all the time, could be hit by itself because it's such an important structure. And the same with your foot, I would think. These are homunculus strokes, right? Where it's only where you are missing the entire function of that functional unit, like a thumb. Then you have your subcortical strokes, and look here, like these threads are moving down here into a point in the capsular, like internal capsule here, and you can from quite a small area get quite a big sensimotor deficit, but without cortical symptoms, right? So that's important. Like, is it subcortical symptoms? Like you only have motor or sensimotor deficits, but you don't have any cortical symptoms like the band symptoms like vision, aphasia, and neglect, and others. Well, then it's probably one of these down here. If it's a combination of the two, then it's usually a bigger stroke where you need to do an embolectomy, like M1 or M2 stroke. Okay. Then moving a bit further with your medullary symptoms or spinal cord syndromes, right? So the spinal cord is one of these pits of endless neuroanatomy that you can just go crazy about because there's so much to know. In my 5-hour lecture, I go through the embryology, which is quite useful to know if you want to know more about this. Embryology in general about the nervous system is really important because then you kind of get the deep understanding of some of the structures. Embryological wise, I will only say that, well, the further in front of the nervous system, like in the anterior you are, the more motor you are. And then further back, the more sensory you are. And it goes for most of the nervous system as it embryologically developed. And the most easy structure is the spinal column, the spinal cord, because it's really anterior is motor, posterior is sensory. And you have 3 tracts going down, and you actually don't only have to remember 2 because 2 of them, these 2, they like strength, like motor function and deep touch. They go together. Touch and vibration go together. So they go down, they cross on the brainstem level, and then they go down and out. Whereas pain and temperature goes all the way down to the area where it has to cross, and then it crosses on the level. That is important when you talk about these syndromes. Also, the other thing that is important is to know that where these are situated, because if you get some of the lesions, some of the lesions are anterior, that would be mostly strength, right? If it's posterior, then it's dorsal column, and then it's usually touch. And if it's in the middle or where it crosses in the middle, then it's usually pain, and sometimes also these. And then you might know that the distribution is like arms our arms right here. For strength is arms like to the middle, and then it's the more lateral you come, the more legs or lower extremity it becomes. So if you get a lesion medially, you'll take your arms, and if you get a lesion laterally, you'll take your legs. But usually you'll get them medially if you do get them. So we'll talk about that in a little while. So usually you get a couple of you have maybe 5 syndromes, like 5. If you take the model that I had before with your triad of tetraparesis, your sensory level, and your urinary anal symptoms, then you can kind of go a little bit further down the deep pyramid here now and give you these 5 syndromes, these 5 gestalts that you need. So one is here. You have your touch is normal, you feel weak, and you have no pain sensation, right? So that's anterior, and that's like kind of the middle. So that would be anterior cord syndrome, right? Anterior cord syndrome here, where you usually have a stroke, where you get what you call owl eyes, because you get like these 2 eyes looking back at you on the MRI. Then you have symptoms where you have crossed symptoms, right? Where you have on the ipsilateral side, you will be weak and you will have no touch, but you will have pain preserved. And here you will have the opposite, the inverse. You will have you cannot feel pain, but you have touch and motor preserved. And most people know this would be the Brown-Séquard syndrome. I'll just show you why this happens. So the motor thing from up here, it crosses on the brainstem level, and it just go down because and then you're strong here. And the same, but the motor here, that doesn't cross. That crosses on the level here, and then it's cut off because it's hemi-lesion. There's a hemi-lesion, right? And the same thing with your sensory. It does travel all the way up, but it doesn't over here. And then with your pain, well, that crosses on the level, so that's all right. You may get some right at that level. You might get some local pain problems, but on all below, it will be all right. And then the one over here that crosses on the level and doesn't really go up. So that's the explanation for it. Then you have this one, which is your touch is normal, but you're weak, but you're only weak in the arms, right? And you have no pain sensation. And remember, in the middle of the spinal cord, I said that there's the arms goes out first, and then it becomes like the middle, and then the legs. And pain also crosses in the middle. So this is where you have what you call your central cord syndrome, usually an hyperextension injury, or a syringomyelia with a weak central canal, where it goes from you can see it here from arms and then out to legs. So your arms are the ones involved first. These syndromes are there's a few syndromes called man in barrel presentations, where it's like you put a barrel over a man's head and put them into a barrel because they cannot move their arms, but you can move their legs. And this is one of the reasons for man in barrel syndrome, central cord. Okay. Then you have this where you have urinary retention and perineal paresthesia. This is the of course, especially if, let's say, you have back pain and you have if you have back pain and you have bilateral leg syndromes symptoms, then whether they're sensory or motor, then it's called equine until proven otherwise. It's important here to know that the anal sphincter tone has been diminished a lot in the literature, even though some surgeons still wants it. If you look at EM cases, they've gone through the evidence of it, and it's really, really weak. Pun intended. So, so it's really we should look at the urinary retention, especially post void, and if they have a lot of urinary bladder, even though they're pain relieved, and they're still like that, then we should do the MRI oftentimes, right? Sometimes they don't have back pain. That's really hard when they come into with urinary retention. You should always just check the reflexes in their legs, right? Common miss. All right, and then we go to the coordination, and that's the end of this. The coordination I won't talk too much about. It's just you can do this chasing finger test, which is probably better than the other tests. That's the only one I actually do. I don't usually do these this diacokinesis test. It's only if my screening is problematic or if they can't do this. And then I go on to some of the other tests. The same way, if you have a really young patient and you can just you just want to rule out that they have anything on their coordination, you could just make them walk on a line where they have to touch your feet, like the feet, the one foot has to touch the other while they're going on the line. And they should like go backwards, and if you can make them go backwards with their eyes closed and they can do that decently, then then you don't have any ataxia. That's like, and most young people cannot do that, but if sometimes they can do it, then it's totally ruled out for ataxia. It's important to know that Romber's test as well is a test where you actually test for peripheral problems. I go into details with that on my 5-hour lecture, so I'll leave you to that instead. All right, and then for this lecture, then we go into groups, and then we'll go through cases where I usually teach, like for every case I'll do the where is the lesion, what is the lesion, and I'll do a probabilistic kind of way of doing it. I've shown it in my 5-hour video as well, so check that out. But for instance, if you have a patient with a thumb that is weak, then you may think, okay, well, it could be in the peripheral nervous system because it might be a lesion there. That's probably most likely. It could be in the central, like a homologous stroke. That's less likely because it's quite rare. And then how fast? Like, what is it? Well, how fast did it develop? It developed like within seconds. Then it's more likely to be a vascular thing, but it could also be just a slowly subclinical develop something that suddenly gives way, like maybe a lesion somewhere along the peripheral nerve, but usually develops incrementally instead, and you get some symptoms. All right, so you do your a priori like pretest probability from your history, and then I'll usually make you choose three tests. Also, could it be no lesion? Well, it could always be no lesion, but maybe not in the thumb question. The thumb presentation is not that likely. Then I ask you, what kind of test would be the most important here? Well, you cannot really like that. There won't be any reflexes to discern peripheral from central. There won't be any like coordination tests you can do either. So what you actually have to do is the motor and the sensory. And what you would expect with your mononeuropathy, right? It would be that the patient has motor and or sensory differences, but accordingly to that specific nerve. So it would be maybe the median nerve or the radial nerve or the ulnar nerve, or maybe two nerves in combination, right? But there's no amount of combination of nerves that would be able to hit the thumb only. And only in certain directions, but like only with certain movements, but not with others. But if the thumb is totally like in all directions gone, then there's no nerve that can do that, right? Because if you cut like all the nerves to the thumb, then it would also give you sensory deficits, right? But the patient doesn't have any sensory deficits. It's like so if it doesn't move in any directions at all, but it has normal sensory function, then it's probably a homunculus stroke. And that's the case here that we present. That's the thing. So that's a way but what I want to teach you is the structure of where's the lesion, what is the lesion. And as I said, these usually are good for sensimotor deficits. But there's one. So now in the appendix here, I'll go through the other approaches to some of the other conditions, so some of the other presentations that we see within emergency neurology. So this is the end of the basic lecture, or the first part of the lecture here, and then I'll just move into the appendix now. All right, so headache, dizziness, and seizures, and I've done lectures on all of these, except maybe not a deep dive in seizures. I will do that at some point, but not right now. So I'll go through headaches and dizziness quite fast, and then maybe seizures I'll do a bit deeper. But so headaches, the approach for headaches is much like chest pain or abdominal pain. It's a pain syndrome, right? And it doesn't really correlate that much with neuroanatomy. So I know some neurologists don't really consider it a neurological thing. So you'll do your OPQRST plus history, and you'll do your maples, and you gather information by opening open questions. Especially, you won't ask like the thunderclap headache whether it you won't lead your victim, so to speak, right? You have to make them tell the history. So you ask, tell me about why you came, and then if they openly say, well, I had this headache and it just bang from nowhere. And then you ask, well, what did you do while you were doing? Well, I was sitting and doing this, but I had to stop, and I like lay on the floor and screamed. then yeah, that's a thunderclap headache. But if they say, well, I got this I got this click, or this like a whip kind of feeling in my head, but I just kept going. It was all right, but it came like suddenly. That's not a thunderclap headache. So it's important to not lead the victim by asking the questions like really narrow. So I could lead the victim saying just, well, did it came fast? Well, yes, it came fast. And was it severe? And then the patient, depending on who they are and how their experiences of their body and so on, they might say, yes, it was severe. Then you have led them into a trap, or let them into your thunderclap algorithm. Whereas asking them openly, then you can assess whether you think it was intense or not. Of course, the patient is always right. If they really think that it was intense, then it was intense. But it's really important how you ask these questions, not and because even the best diagnostic workup, even the best test, is only as good if you actually assess the patient instead of just doing the algorithm. Okay. Then you do what you call Snoop 10, and in my headache lecture, I've told you about what that is. These are the red flags for headaches, but you shouldn't use them as a screening tool, because if you check them off all of the time, then you will have to CT scan almost all of the patients. Then you'll know about the important illness scripts as well. Like as with chest pain, you have like the 6 important time critical illness scripts that you need to know about: your ACS, your pulmonary embolism, your perimyocarditis, your pneumothorax, your aortic dissection, and your upper GI problems such as pancreatitis, such as ulcer, and so on and so forth. And then maybe the 7th is pneumonia. In the same way, you have a lot of like a priori, you will have a couple of, like depending on the patient's age and demographic, you will have some of the most a priori time sensitive and likely as sannsynlig conditions. So this is I usually, when I teach, I do this, because in emergency medicine, we are concerned about the time critical ones and the likely ones. It should be an L, not an S here. These are the ones that the differential diagnosis or illness scripts that we are interested in. And as we gather information, then the landscape of this changes, right? So a priori, we might, with anyone with a chest pain, you will think of these 7 diagnoses that I just mentioned. But once you go to once you get your gathering your information, a lot of these becomes less likely. They move down here. Some of them a lot of them moves down here because they were too unlikely. And then you usually have 2 or 3 that you have to think about, work up, and then do the tests for, right? There's an important thing that that I like to mention, and that is in emergency medicine we do, like Ruben Strero has this sun that I have used from time to time in some of my lectures, where you have these 150 maybe diagnoses that we all need to know, like illness scripts that we all need to know in different presentations and how to treat them. But these are the time critical ones. But sometimes we also need to know how to treat the non-time critical ones and find the non-time critical ones, but the likely ones. And the reason why, especially if these syndromes or if these illness scripts that would be for the ones that would be categorized over here is very likely but not time critical, it would be like gastritis or pain, musculoskeletal pain. The reason why we don't like these diagnoses is that there is no good test to actually discern them from these, right? Musculoskeletal pain, like everyone is a bit sore on their chest when you palpate them, but if you can palpate the entire thing, there's probably a better test than that. But gastritis is a terrible diagnosis because you cannot never, like, even though you pain relieve them with Pink Lady or whatever, you that's not a good test. That will also help a lot of these conditions. So the problem is here, like, but you can use these conditions. I usually use the case of BPPV in dizziness because this is a benign thing. But if you can see that there's a nystagmus when you're provocating with the Dix-Holpike, and it's like classical geotropic nystagmus with a torsional component, then it's really a high signal. That's a good test in a patient in a illness script in this category, and if you can rule that in, then the reason, like the likelihood of these goes way down, right? So that's why we sometimes need to know these to be able to rule out the more dangerous stuff. And that's, as I've mentioned in my lectures, that is assuming that you have 100%, like the patient only has one diagnosis. Please look for my videos on landscape of diagnostics to get more into this. But for headache, let's check out these. So for headache, the more important ones are like thunderclap headaches, and the most like subarachnoid is like 10% of all monosymptomatic subarachnoids, and then next most common is RCVS, and then you have certain presentations that could present with monosymptomatic thunderclap headache, but usually don't. Like dissections usually don't present with like this. Monosymptomatic headache is usually presented with a bit more like neck-like pain, and not oftentimes more gradual. CVST, which is central venous sinus thrombosis, only in 10 or 15% are monosymptomatic and not thunderclap headache necessarily, but I think it's like 5% of them present with thunderclap headache. ICH, well, they can present with a sudden and severe headache, but they will always have a neurological deficit. All right, so it's not monosymptomatic. And spontaneous intracranial hypotension is a really, really rare one. It can present with monosymptomatic headache, but a lot of these, like what you think is thunderclap, like the most important thing with thunderclap headaches, as I said, is if it's not obviously thunderclap, like with neck stiffness, subarachnoid or something like that, then you should probably just ask the open-ended question and assess whether is it a thunderclap headache or not. Is it intense, and did it come suddenly? And be aware of, also I forgot to mention, be aware of the stoic patient. The stoic patients, what we think is intense, they don't think is intense, right? There's this great Dr. Glaucoma, like in Rural Medicine sketch, where he asks, well, a farmer came in, and then it's like, oh, did his wife make him come in? No, he came in by himself. What? Yeah, that's really a red flag. And then he said, like, oh well, but did he finish his chores? No, he had to come in because it hurt too much. Well, that's that's a high red flag. So the stoic, and then that sketch gets at a really important thing. Like the stoic patient, if they come in, they will usually diminish their pain, but they came in and they don't really come in any time ever. So if you have someone with a headache that came suddenly and they came in for the first time and they're like stoic patient, then think about thunderclap headache, even though they don't think it's intense. They stopped their chore, right? They stopped. They didn't roll around screaming, but they had to stop. All right. The other ones are extracranial headaches are really important to think of, and we think too little of them when we think about headache. But it might be glaucoma, might be dental abscesses, it might be medical overuse headaches. That's really a common secondary headache. Like giant cell arteritis, post-septal cellulitis. They're like extracranial ones that are important to know about, that are time critical. Then you have your systemic ones like hypertensive crisis or CO2 poisoning. There are others as well. And you have your other intracranial ones like space occupying lesion and pseudotumor cerebri or idiopathic intracranial hypertension. IIH. Sorry, I forgot what it's called. Pseudotumor cerebri is the other name for it, right? Usually, like your 30 to 40-year-old, or 20 to 30, 40-year-old, usually female, overweight patient, or with weight changing. And then they have vision difficulties, and then there are or abducens paresis, and they are having headaches, right? That's something that you need to keep an eye out for. Idiopathic intracranial hypotension, yeah. Then you have infection like meningitis and traumatic bleeds and shunt dysfunction and so on. And you have your pregnancy-related ones like preeclampsia, breast estrogenic tumors, and pituitary strokes, especially like preeclampsia. Just saying, like, these are some of the time-critical ones, depending on which group you have. All right, I've done an entire lecture on this about probabilistic thinking and headache, which also goes through a lot of the probabilistic thinking in general and communication and compassionate care, which I highly think is very, very important. So please check that out. All right, then dizziness. And dizziness is you can have you have your red flags here if you have dizziness plus something. Then you have your headache. If you have dizziness and headache, or dizziness and you've just been out diving, these are red flags. You have neurodeficits. If you have dizziness plus a neurodeficit like a weakness or a Horner syndrome, or then it's always a CT scan, right? And remember, the CT scans for the areas which involves dizziness centrally, it would usually be the posterior parts and the cerebellum and the brainstem, and the CT scan is really bad for this area. You usually need an MRI, and that's why we're doing the stuff like the HINS test, because it's better in the first 48 hours. All right, so you need to do the right scan. Then you have your acute instability, like if your patient with dizziness cannot sit or walk without assistance, then you might have this acute instability syndrome, and then you should always have a scan as well. And think of stroke and central causes. They are allowed to be wobbly, that's all right, but they should be able to sit with their arms crossed, and like eyes closed. They shouldn't have truncal ataxia. That's the neurological term for all these things. They should not have a truncal ataxia. The problem is when they are at baseline quite bad walkers, or they're frail, then it's quite sometimes hard to discern this. But the young patient that could walk yesterday should be able to walk, just a bit worse, but they should be able to walk without assistance when they were dizzy. All right. Triggered episodic vestibular syndromes versus acute vestibular syndromes. Make them sit still, as we talked about with the nystagmus. Once they sit still for 5 or 10 minutes, then you try to test them, see if there is spontaneous nystagmus. If they don't have spontaneous nystagmus, and if their history sounds like BPV, then you do the Dix-Hallpike and head roll test. And if they are positive which I've talked about in my dizziness videos. Please take those out for details. If they're positive, then you'll do Epley's maneuver for the X-Hold-Pikes, and for the head roll test, you will do your Guffonies, and if they have cupulithiasis instead, then you'll do a third test, right? So, and then you have AVS. If you have a true AVS, meaning that it's a constant dizziness that doesn't get much better when you're just sitting totally still, and they have spontaneous nystagmus or gaze-evoked nystagmus, meaning that when you're making them look to like when you're doing your tests for motor eye movements, then you shouldn't test for nystagmus by making them look in the extremes of their angles. You have to make them look at 2/3 of their like extreme angle of their vision, because a lot of patients have end lag nystagmus. I think I can't remember the English word, but when you're looking at the extreme, they will get a little bit of nystagmus, and that's normal. So you have to test them at the 2/3. If they have spontaneous nystagmus or nystagmus from gaze-evoked nystagmus, then you'll do your Hinz test, and if sometimes you'll do Hinz plus test, and if all the 3 to 4 tests in the Hinz plus test points towards the peripheral, and they don't have any of these things, then you'll call it a vestibular neuritis usually, and treat them accordingly. If they have hearing loss, which is part of the Hinz plus test, then it's kind of, if they're inflammatory, then it's labyrinthitis. If they're not inflammatory, then it might be an ICA stroke, and then you'll treat it as essential. If they have any of the 3 to 4 features of just one of the Hinz tests, then you'll think that then you cannot rule out a stroke, and then you'll treat them as a stroke, and so oftentimes they'll have an MRI in 48 hours, 24 to 48 hours, and then you'll have a diagnosis. Yeah. So for dizziness, here's Peter John's algorithm. I like it because it's simple. Does it sound like BPPV, and do they have no spontaneous nystagmus? Well, then they will do the X-Hold-Pike tests, and you'll have to know the nystagmus of the X-Hold-Pike test. If they do have constant nystagmus, then you'll do an AVS test. If you do have spontaneous nystagmus or gaze-evoked nystagmus, and they have constant dizziness, then you'll do the Hinz test. And if they do have any of the red flags, then you'll just go to CT scan. I would usually do this anyway to get some more points, because the CT scans don't work that well, right? So, but just know that you should not send someone home who has any of these features up here. All right, I've done a lecture on this before, so please check that out if you want to know details. All right, then we move on to seizures, and I'll spend a little more time talking about seizures. So, a couple of my pearls on seizures are usually don't talk about the syndrome transient loss of consciousness instead of seizures, unless you see the seizure and you know about semiology, like seizure. Like, I'll be using the word semiology, which is an episode, like the description of an episode of epilepsy, like usually used in this description of epilepsy. Like, what are the details? Do they have open eyes, or do you have closed eyes? Do they have high is it the crescendo decrescendo kind of amplitude in your shaking? Is it both sides? Is it just one side? Does it come gradually from hands to arm, like what you call a march? Or does it come all at once, so on and so forth? That's the semiological description. That is really, really important. But before you get to that, I would like you to frame yourself a cognitive, force yourself to call every time someone calls it a seizure, say, no, it's not a seizure, it's transient loss of consciousness. And because then you don't get into the trap of thinking, well, seizure, then it's epilepsy. Because transient loss of consciousness can be syncope. A lot of the syncopes have, to the untrained eye, they have post-syncopal myoclonias, which can look like seizures. So please check that out. And then they might not even be loss of consciousness, right? If they have pseudo seizures, then they're not really loss of consciousness, or like dissociative seizures, we might always also call them. So think, like, don't avoid the framing bias. Convince me why this should be called a seizure. Just call it loss of consciousness with movements until proven otherwise. So when you have a loss of consciousness with some movements, what kind of things would count or would suggest that it's an epileptic event and not something else? Well, you'll get your semiological description, often by bystanders, or you have to call someone, get a proxy history to get it. And you have to get it quite detailed. It's really important, like especially what are the eyes doing. For epilepsy, usually they're open and they have no pupil response. That's sometimes why they shine a light into your eyes. Usually the amplitude would be like kind of going from down to up, and then it will have a peak, and then it'll go down unless it's a status, right? But most seizures are not statuses. They're usually only a duration of 2 to 3 minutes. If they have a duration of 2 to 3 minutes, then it's highly likely to be below 3 minutes, maybe 1 to 3 minutes, then it's highly likely to be a seizure. But if it's like just 30 seconds or 10 seconds, then it's much less likely to be it. Or if it's much more than just 3 minutes, then it's also very less likely to be it, unless it's a status. But if it's a status seizure, then you'll usually know it by the way that the patient is seizing. And I'll get into that when we come, because the main differential for status cramps or seizures is dissociative seizures. All right, so you have to have a decent semiological description. It's important to know that a lot of the patients that seizes have had seizures before, and it's important to look at how stereotypical is this seizure, as opposed to their previous described seizures. So it's important in the charts to describe the semiology quite well, because if the seizure that they're having now is very different from the seizure that they usually have, their main seizure, then you should think of maybe it's a different thing, right? Maybe it's a different kind of seizure, and maybe it's meningitis, or maybe it's some pseudo seizure. Because if you have epilepsy, usually sometimes it will be familiar epilepsy, like genetic, but most times it will be something acquired. Especially as you get older, it will be something more like acquired, like a post-stroke epilepsy. But usually you have one kind of semiology, and it will look the same each time, so it's stereotypical. These are really important concepts when we think about your patients with seizures. The familiar seizures, like juvenile, I can't remember them now actually, but there is these familiar kind of seizures that you get as a young person or a child, and that'll follow you into adulthood and your rest of your life. Oftentimes these usually have 1 to 3 semiologically stereotypical seizures. So be aware that some syndromes may have 2 or 3 stereotypical ways of presenting themselves. And this is also something we talk about, ask the patients about if they had come in and had a seizure. Well, have you ever had, if they had 2 seizures in a day? Well, did you ever have 2 seizures in a day? Well, if they didn't, then it's different, right? And if they don't have a good explanation for why, or they don't have good follow-up, or they don't have someone to take care of them at home, then even though they have seizures all their life, then maybe sometimes we have to admit them, right? But oftentimes, a lot of the patients that are coming in who had seizures, they had it in public, and that's why we oftentimes can send them home if they're not in their if they're not in the middle of transitioning between two kinds of meds, meaning that they're off one med and on another. Then it's usually okay to just send them home if they haven't injured themselves, and if they have someone to look out for them. There are some tests that are more specific, or some features of a patient who has had a transient loss of consciousness that would say that it's more likely to be a seizure, and that would be the lateral tongue bite. It will be a post-ictal confusion. These two things are the most specific ones for a transient, like for a seizure. They don't always appear, because you had to have a global kind of seizure, like both arms and legs are shaking. What you used to be called a grand mal seizure. You usually have to have these. So for the focal seizures, it doesn't really help. But and then there's one feature as well, like what I call look into my eyes. You grab the patient, you talk with them, and then you'll if you can catch their eyes, then it's not a seizure. If you like, if they can look into your eyes, then it's not a seizure, because you cannot consciously shake in both. You cannot shake in both your extremities, and then consciously look into someone's eyes. That's impossible. I'll show you how in the next slide. But then if you can do that, and that's usually what I do. If I think this is a dissociative seizure, then I'll usually try to talk with the patient, sit down at the bedside, shake their hand, and clap their hand or clap their cheek, and to kind of like be really like compassionate and empathic with them, and try to like catch their breath. Catch your eyes, and if you can do that, then usually then often it dies down by then as well. When you talk them down, and you'll avoid getting them intubated. And do it with a non-stigmatized like kind of approach, because these patients don't do it at their own. They don't. When I explain it to patients when they get out of it, then I usually like, well, you had an event, right? You had an event that was unconscious, and it's hard for us to always know whether it was epilepsy or it was dissociative, but both of these diagnoses are important, and they are treated differently, but they're really important that we get this right. And I'm telling you right now that I think some of the features that you've shown was dissociative. And this is not something that you do by yourself. It's not something that you do consciously. It's something that can happen to almost all of us, right? If we get in the really extremist situation where we kind of dissociate from the world, because that's our coping strategy to cope with it. It's really important, like, to know that they're not faking these things. Almost never. And even if they were, that's a bad way of looking at it in the beginning, because you will lose your alliance with the patient. For more on that, check out my other lecture or Susanna Solomon's book, It's All in Your Head. All right. Then there we have something that may be useful: lactate, muscle soreness, and post-ictal Babinski's positive is sometimes these may, but they're not that specific. It can happen with other stuff, especially lactate is something, and muscle. Pseudoseizures can easily have a higher lactate and muscle soreness, because they're ceasing. They're usually like moving for like 20-30 minutes at a time, sometimes much more. And the ones that are not useful these are like bowel and bladder movements, because that's any real transient loss of consciousness can get this problem. Then I didn't talk about like my approach to these patients is usually like the transient loss of consciousness, which includes syncope, like what happened before, what happened during, that's the semiology, and what happened after. And depending on the history, as you know, with syncope and the cardiac syncope versus vasovagal syncope, then these there are certain features that here in the most seizures don't have any before features. They only have this just happens. They might have a cry or something like that, a pre-ictal cry, but most of them don't have anything. It's usually in the semiology, and the semiology is usually 2-3 minutes, and so on and so forth. So what I just described. Cardiac events is just usually an down and up, right? They don't have any post-ictal features unless they hit their head, which makes it hard sometimes to discern the two, especially if there's bad historians and they don't have a proxy history. Then you usually just have to admit them for CT scan and telemetry, and then it'll have to show itself. All right. Then you have your status epilepticus, right? And status is usually if they've been seizing for more than 3 to 5 minutes, and you don't think it's dissociative. The most important thing, there's lots of studies has come out in the later years showing how bad second line drugs are. So the most important thing is don't give benzodiazepines right away, because most seizures stop within 2 to 3 minutes. So you can draw up benzodiazepines, but you shouldn't give them before they've ceased, because otherwise you'll just end up giving them a lot usually. So, but if it's someone who sees more than once at a day, that day, then yes, especially if they've been post-ictal and not recovered in between, then that's definition-wise, that's a status as well. Like for a long time, or they haven't recovered in between there two because of post-ictalness, then that's the status. All right. The most important thing is to give it fast. Once they're above the 5-minute limit, give it fast and give a high dose. Doesn't matter what drug it is, actually. Give the one that you can. So first line is benzodiazepines. Doesn't matter which one. There's no evidence for which one it should be. No evidence that one should be better than the other. So give the one that you have, and then that you're comfortable with, and then you're comfortable with giving in a high dose if you need to. And once you've tried twice, in some guidelines thrice, then you'll have to move on to the second line, which usually will be either Keppra, levetiracetam, valproate, or phosphonatoin. It's important to know that phosphonatoin is cardiotoxic and needs telemetry, and you shouldn't give it to TCAs. It's important to know that valproate is potentially hepatotoxic and shouldn't be given. Should probably not be given to alcoholics if you have other choices. And Keppra is pretty side effect free, but it has some emotional problems if you need to put someone on it for a long time. Also, if you have an epileptic that goes into a status, don't load with the same drug that they are using unless you suspect non-compliance. Also, if you do have a sometimes you'll see neurologists double load patients. So you start off with one second line drug like Keppra, and then you'll have the next one would be maybe valproate. It's important to know that phosphonatoin and valproate should not be combined, because they kind of mix up their metabolism with each other. So don't combine them neither chronically nor acutely. And then, like, empirically, without knowing the cause, then if they've been seizing for a longer time than just a couple of 5 to 10 minutes, then usually you'll go to when you loaded them, then you have to call anesthesiology, and you already you have 3 stages. Like you have first line, second line, and third line is propofol. And then there's a fourth line as well, sometimes when you get ketamine with the extreme long seizures. But usually when you get these patients, then they've been seizing for a long time pre-hospital here already. They're already getting their 2 doses of benzodiazepines. So if you get one of those patients, well, then I usually call anesthesia right away. And then in the meantime, while they get there, I will tell the patients my nurses to draw up Keppra. And remember to give it a good dose, right? The dosing I can't remember here, but I think it's like 30 milligrams per kilo. Is that right? No, that's not right. Sorry. It's but you should give it the right dose, right? So usually it's 3 grams of Keppra, something like that. for a lot of patients, right? And oftentimes underdosed. So give a high dose and fast, right? That's the motto here. Parallel, it's really important to think about what could be the cause of the seizure. Sometimes you'll get it from the history, it's non-compliance, or they're abstinent, they're alcoholics, right? But a lot of times you won't. So the venous gas for hyponatremia, knowing that they're pregnant like week 20 to postpartum week 6 to 8, that's where you can get your preeclamptic your eclamptic seizures which needs magnesium. These needs hypotonic saline. You can have your structural damage problems like CNS infections, bleeds, and so on. You can have your cardiac arrest. Sometimes starts with your seizures. If you saw Christian Eriksen's seizure with his cardiac arrest in when he played football in Parken, then yeah, that's one of the. It's important to be aware that sometimes when people cease, it's because they're in cardiac arrest, and they will stop ceasing, then they will be in cardiac arrest. So it's important to know that. Hypoglycemia, and so on. And you have to prevent the complications while you're doing it. So start the clock, because you won't be able to know the time anyway afterwards. Then give O2 on mask, and then protect the head. Don't put anything into the mouths, but protect the head with cushions, and move out stuff from the bed that can hurt them. All right, and then you kind of treat symptomatically. All right. So it's important to know that seizures are like a threshold kind of thing. Everyone can cease if they are provocated enough. And there's like three. If you have a patient with a seizure, it's important to let them know that it's like one event it's really hard sometimes to discern whether it was a seizure or not. There are three, like the ILAE, the International League Against Epilepsy, usually has like these three criteria for epilepsy, and it's criteria 1, some certain pathognomonic EEG patterns. EEG is really a very weak test. It's quite insensitive and quite not specific, unless it's really certain patterns. So, I think it's like 10% of the population have pathological EEGs, even though they don't have seizures, maybe more. So it's really dull kind of test. So the patients shouldn't suspect that they get a diagnosis just because they get an EEG. The better test would be the monitor EEGs, where they go into like a clinic, like in Denmark, the Philadelphia clinic, and then they stay there for a week or two, and then they will see whether they have the seizures during that time. Also with telemetry, because sometimes they have cardiac arrests instead of seizures. And if you want to know more about that, then check out Susanne O'Sullivan's book, Brainstorm. All right, but back to the criteria. So the first criteria for seizures or for epilepsy is usually these pathognomonic kind of EEG patterns, and that's like West syndromes, like childhood spasms, and a couple of others that are really like pathognomonic. That's the first criteria. Sometimes that's a criteria that sometimes can give you a diagnosis. The second criteria that you can give a diagnosis is if you have a certain probability of this like developing seizures, and then having a quite like something that might be a seizure. Like if you have if you have a patient who has a stroke, and then a couple of years later they develop something that seems like a seizure, then you can give just by one event you can get a diagnosis of seizure or epilepsy. But otherwise, you'll have to get to the third criteria, which would be I think it's several stereotypical seizures, more than just one event. All right, so one event is no event. It has to be at least two usually, unless you have risk factors. I think it's like that. Check out the ILE for specifics. it's important to know that also when you see your patients with epilepsy, they should not swim, they should not drive cars, right? Unless they have specific reasons, unless they've been followed up and they're seizure free for a certain amount of time, depending on the country where they live. But it's important to know that around 50 to 60% of patients will not ever get seizure free, and epilepsy is we think of it as like something that is quite benign, but it's quite there's a lot of like nuances to this, and it's horrible for people knowing that any time they could just cease. So it's really a invalidating disease that is, and there's a huge spectrum of presentations. And then please check out Susan O'Sullivan's book of Brainstorm. Is really paints a really good picture of how deep and complex these conditions actually are. All right. One thing I forgot to mention is important to know about frequency of the seizures as well, along with the stereotypicalness and the semiology. If you used to have like a few seizures and suddenly you have a lot of seizures, then without changing medication, then it's something that has to be looked up on, right? Also, you need to assess for risk factors like sleep deprivation and alcohol and stuff like that. That's common features that might be the reason why you have a higher frequency if you don't sleep right now. But moving back to this picture, so this picture is we all have a threshold, right? And I used to work in psychiatry as well. As an intern, and when you work in psychiatry, oftentimes you have these ECT, like electroshock therapy calls where you are the one giving the patients these electroshock treatments, which are, if they're done right, really 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 helpful. I'm for them very much. But what you know there is that every patient can cease, right? That's what we induce there, and what we do give some drugs that actually does so that they cease more or easily. And a lot of the anticholinergics will make the antipsychotics and theophylline will, like the asthma medication, will make your threshold become a bit less, and you'll actually cease more or cease easily. Some of the things the other things that make you cease easily is like these things that we just talked about, like if like the reversal causes, like if you have hypoglycemia, if you haven't slept, if you have a lesion in your head, all of these things, like if you have several of these, then you'll cease much more or easily than if not. So you have to correct sometimes several of these things. And then of course, if you have a anti-epileptic drug, then oftentimes you'll cease less. If you don't have any of these, you'll cease less. And then sometimes ketogenic diet might help some patients if they can follow it. And yeah, common things. So common triggers for seizures are usually medication-wise, like non-compliance in your patient that has ceased and now it doesn't cease, but you see them in the emergency department. Should you send them home or not? Well, it depends on the stereotypicalness, the frequency, the semiology, and their complications. Did they hit their head? Did they hit anything? Can they be observed? Is it common for them to have more than one seizure in a day, depending on how many seizures they have, and so on? And then you have, like, are they compliant with their medication? Are they currently changing their medication, like crossing over usually? So they go down in one medication and go up in the other. Have they started on other drugs that might interact with the AED, the anti-epileptic drug? Are there any other things like medication that might make their threshold for seizures lower? Are they in imbalance, like are they not sleeping well? Are they psychosocially stressed? Do they have other triggers like Rarely it's like light, like strobotropic light is really rare, but sometimes fever is a cause, or other stressors of the body. But it's important to know, like, it's sadly it's 2/3 of the people, or a little more than 2/3 of the people, or so a little more than 1/3 of the people with epilepsy diagnosis don't ever get seizure free. They like the first line drug will make 50% seizure free. The second line drug would be make 60%, and then you have some that needs to be considered for epileptic surgery, and that's usually the ones that have a structural lesion or a structural reason for it. Again, read in Susanna Sullivan's book Brainstorm for details. All right, and here's the some of the treatments for the specific causes. It's in Danish, sorry, but I'll just meningitis is of course treating the underlying cause, and encephalitis as well. Hyponatremia is giving hypotonic saline in these doses. If you don't know how to mix it, then you usually can get bicarbonate as well. It has the same amount of sodium. Hypoglycemia is always like giving glucose and then making sure that they're not on a long-lasting insulin. Because if they're on a long-lasting insulin, you have to admit them usually to actually make sure that their insulin won't work again once you should send them home. Then you have hepatic encephalopathy. That's kind of I've never seen one cease on that, but it can. And that's of course like treating the underlying cause as well with lactulose and so on. Uremia, I've never seen that either, but you have to dialyze them, of course, or treat the hypo-K and so on and so forth. Intracranial pathology depends on what kind of pathology it is. Remember, you should always do a CT scan if someone has seized for the first time. Sometimes you need a specific CT scan, like a sinus venous, like a venogram. For picking up the sinus venous thrombosis. Eclampsia, you'll give magnesium, and you'll give magnesium until they lose their reflexes. Once they lose their reflexes, you'll stop, and you'll give this quite high dose. I think it's like 2 to 4 grams, even more sometimes. And TCA poisoning, you'll get bicarbonate. If it's hypoperfusion, you'll have to do like cardiac arrest, and you'll have to do CPR, so on and so forth, right? There are other. It's not all of them, but a lot of them. All right, and the last slide here is just seizures. So seizures. The important thing is here. This is a concept that I think have from Furlow's book, the neurological examination made easy. And I think it's really good concept. So. In order for you to lose your consciousness, you have to have a lesion here in the Arras system. This is what happens when you get a stroke, top of the basilar stroke. Then you'll lose consciousness just by one lesion. Otherwise, you'll have to have 2 light bulbs out. You have to have 2 lesions. There's something called the Percheron artery, which is an artery that goes to both areas, meaning that one stroke can make you lose consciousness because it hits both brain areas. It's really rare. One of my friends has seen it in clinic, so it does exist, but really, really rare. So in general, you will not lose consciousness by having a stroke. That's really important. You will not, because strokes are usually just it's almost always just on one side. So you can, after a couple of days with a stroke, get a mass effect, so that you get for instance, a malignant media syndrome, where when you have edema developing and you push, but that's where and then it's pushed, and then it's because of mass effect that both lights goes out. So why is this important? Well, first of all, the first take-home point is you don't syncopize with stroke. Easy as that. You don't have a transient loss of consciousness unless you have developed epilepsy along with that stroke, right? And then of course you have these are really rare causes like the Percheron artery, and you have the Arras system stroke. but you don't, as the rule of thumb, don't have loss of consciousness with strokes because they only hit one place. Okay, one light bulb. All right, next one. When you have a patient seizing in front of you and then they're moving both arms, then they're having a global seizure, right? They have to have both hemispheres involved because this side controls this arm and this side controls this arm. Okay, if you have both hemispheres involved, then it's a general seizure, and with general seizures, general or complex seizures, then you will have loss of consciousness. You will not be aware. But if you can catch someone's eyes, then you are aware. Right? If they can look around, or if you can catch their eyes, that they can speak to you consciously, then they are aware. So if they're moving both hands, but they are speaking consciously, that's impossible. And then my third take home, I guess, is like there are certain kinds of seizures, right? There's the focal, like I know ILAE has done a new kind of way of talking about seizures, but I think the old one was a bit better to use for non-neurologists. So you have like simple or complex seizures. Simple would be where you're awake. Complex is the ones that where you're not awake. And then you have focal or generalized. So the generalized ones, that's like the 2x2 table. So the generalized seizures are always complex, meaning that the generalized seizures where you have both hemispheres involved are always with loss of consciousness. You're not aware when you're having them. So if the patient remembers as well, that's also something like that doesn't sound like a seizure. If they remember what happened during the seizure. If it was a bilateral, like complex seizure, then again, if you have focal, that can be that is usually a seizure of just one limb or something like that, and then it doesn't have to be a seizure with it doesn't have to be a focal seizure with limb shaking, or it can be an ANS, like it could be the hair of your skin, the hair of your skin on one side rising. It can be emotional ones like mesial strokes. You can have really complex movements as well. You can walk around and run suddenly, and there's lots of different seizures, and like during the nighttime, sometimes you can have these as well. And you can have terrors as well, like emotional seizures. But it's important to say, like, focal seizures usually can be simple or they can be complex as well. So you can be awake or you're not awake sometimes as well. And then of course they can start in one area and then it can become generalized, secondary generalized. So that's kind of like 101 in seizure management and how to manage like the non-emergent patients with seizures and the emergent patient with seizures, right? And the status as well. So that's the end of the lecture, and thank you so much for listening. Yeah, sorry, before I go, I just wanted to share with you a bit deeper dive about dissociative seizures. So we already talked about that usually they are response to emotional stress, sometimes physical stress. It's like dissociating from reality. It's like a coping strategy. It's usually subconscious. There are some risk factors related to being of a psychological frail state, such as being abused as a child and so on. But it's not like having dissociative seizures doesn't mean that you've been abused. It's just a small risk factor. All right. Most of the patients that have dissociative seizures have not been abused, have not necessarily anything psychologically wrong with them. Most are normal people like you and I, who either partly by the system has been put into a box that they don't belong to, and then they have kind of adapted to that box. Something that Susanna Solomon calls looping effect. And it's definitely something that is worth looking into. If you want to know more about it, then please check out Susanna Solan's books on like this is all it's all in your head and the Sleeping Beauties. But so here I think it's really important to know that, and I think it's important to keep an open mind when you have someone who has several of these features that I will talk about, because you should keep an open mind that it may be an atypical epileptic seizure, but I think you should highlight that it might just as well be a dissociative seizure, and I think it's early on in the diagnostic process that you need to have this as a differential and tell the patient about it, that it could be a differential in a non-stigmatized way. Right, this is really, really important, I think, because if it's an like epileptic event, then they have to be treated in one way. If it's a dissociative dissociative seizure, then they have to be treated another way. It's both of them are really invalidating for their lives, and both of them can turn chronic if they're not treated. And it's not something that the patient can help, so they need help with them with it no matter what, right? One condition should not be seen as a lesser condition than the other. Okay, I think I talked about enough about that, and now we have to talk about how do we actually experience these, or how do we as clinicians become aware of these? Well, so this is a diagram from Handbook of Clinical Neurology, volume 139, which is a huge, very, very deep book about functional neurological disorders in all shapes and forms. And if anyone is, I feel this is really, I know this is a kind of a tangent in emergency medicine. This is really not that related to it on the surface. But if you look into it, there's really, really a lot of it is related to everything we do every day. Think about neurology and functional disorders and life circumstances and biopsychosocial circumstances for symptoms. They can be tested because of the 1-to-1 ratio in neurology. They cannot be tested in the same way in cardiology. There we have to do all the tests, and then we find the baseline cardiovascular risk factors that everybody has, and then we think it's a disease, and we treat it as a disease even though we didn't acknowledge that it's usually actually a problem with their underlying anxiety or conditions and so on. So you might say that some of the patients turning up in neurology clinics are lucky in some ways, because we can then assess whether it's true or not that they have these things, and then we can help them with their subconscious problems and make them conscious for them so that they can work on them. But medicalizing patients will not do that, and that's, I think, is what we do in a lot of the areas of medicine where we cannot have this 1-to-1 ratio. Chest pain, any pain syndrome, really, where we keep doing tests to think that it's actually somatic disorder and not addressing or not entertaining the idea that it might be psychosocial as well. Okay, there's more specific things that we look for when you have someone seizing in front of you. I told you to, if it's, we talked about the semiology. There are certain semiological features that looks like epileptic seizures, and we'll talk about them in the next slide. The ones that look like not like dissociative seizures is that if they have preserved awareness, like take their hand, talk to them, and see if you can catch their eyes. If you can catch their eyes or get other glimpse of awareness, if they're if they're moving both body parts, both like parts of their body bilaterally, and it's, as I said in the previous slides, virtually impossible for them to be aware if it was a real seizure or if it was a epileptic seizure, I should say. Yeah. So preserved awareness is really highly specific. It's not always you can find this. Some patients are so far gone in their dissociation that it's hard. But I often find that really you have to take a moment, hold their hand, and I don't do the drop their hand on their head. It's like I think it doesn't really, it's not useful, because it kind of subconsciously induces the idea that they're faking it, and they're not. They will not be able to move their hand away from their face, because it's not consciousness. They have consciousness, but you have to like it's not, it's subconscious what they're doing. It's dissociative, right? They can't just snap out of it just by themselves. Usually they have to get a bit of help. Yeah, then there's other codes, like other things like eye flutter. I've never used that actually. And the things that they can sometimes, like the it can be crescendo, decrescendo, and then crescendo again. Like the seizure can go up, then can go down, then up again, then down. That's also quite pseudo seizure, like because usually seizure activity goes up, has a stable phase, and then it goes down, or it keeps on the stable phase, becoming a status epilepticus. It doesn't go up and down all the time. And then there's less sensitive or specific things. And we'll just move on to the next ones, because these are the ones that I usually use. Certain movements, like there are certain movements that are really not classically seizure-wise. It looks like seizures, but I've been fooled with some of the more complex seizure syndromes sometimes, but so it's not really that specific or sensitive, many of these. The thing is, though, I will highlight, is seizures longer than 3 minutes. It can be status, but if they have eyes open, especially at the peak of the seizure. Sorry, if they have eyes closed, especially in the peak of the seizure, and it lasts like maybe 5 or 10 minutes or 15 minutes, and they have their eyes closed still. That's usually, we'll see in some of the other slides, that's usually one of the signs that might say that it's not epileptic. Here are some of the features that says that it's epileptic. We talked about post-ictal phase or confusion. We talked about the abrupt onset as well. And we talked about eyes wide open in the beginning of a seizure. All these things are something that counts highly towards this being a seizure. Then there are some specific seizure movements, like ictal cries and grasping and automatisms on the hands or the mouth, and like stereotypical speech, like saying yes or no, but not like more deep kind of like conversational speech. And once a seizure becomes non-convulsive, it's important to look at the eyes, especially because there might be some small twitches left there, and that's how you can see there's seizure activity sometimes. Otherwise, you have to do a test with benzodiazepines. But these are like common features. So and also tongue bite, lateral tongue bite. I'm not sure whether it's here or not. It's also one of these really important features. Here's a comparison between the two, like psychogenic or dissociative seizures, BNS, and epileptic seizures. So usually concurrent tongue biting on the side of the tongue, as I said, is really common in the generalized tonic-clonic seizures. Not all the seizures, though. The focal seizures don't have it. Shorter seizures don't have it usually. It's really rare for the dissociative ones to have it. Then the ictal grasping of the hands is rare. Automatism and so on. Here, closed eyes during the peak of the ictus. That's very common in the psychogenic ones. That's rare in the epileptic ones. They usually have open eyes. And it's really important to ask semiologically detailed about how the eyes were. What are the eyes doing? Are they closed? Well, it's usually a dissociative, a strong sign of dissociative seizures or something else. Okay. Prolonged duration, as I said, that's rare with epileptic seizures. We do see it in status, but it's not really that rare. It's not really that common as we think. Whereas it's really common with the dissociative ones because they don't have a clock. And then you have like all of the more common ones you hear in books on like asynchronous movements, side to side head shaking, or like things that are not in the in the normal plane of movements for epilepsy, like yeah, pelvic thrusting, more complex movements, sometimes guarding or dropping hands, yeah, so on and so forth. So it's just to see that there's a literature about these things, and it's important. This is a rule-in test. A lot of these tests are rule-in, so I would suggest that you check the eyes, see if they're open or closed. Check the semiology. Check see if it looks like if it's been going on for more than 3 minutes and it looks like it's going up and then down and then up and then down again in frequency or in amplitude. And if the patient has a history of earlier dissociative seizures, then probably try to take their hand, try to talk them out of it, so to speak, or try to reach them, I would say, and then go from there. Don't rely on the lactate. Don't rely on the other things. And then once they get out of it, see if they're post-ictal. If they're not post-ictal, but they just ceased for 10 minutes, if they're not like deeply unconscious or have Babinski positive or are confused and psychotic almost, then it's not post-ictal, right? Again, so this is there's a lot of data points here, and some data points, as I just mentioned, are stronger than others, but it's definitely a diagnosis that we can entertain and make, and we shouldn't be that afraid of doing it. Because the features that we see are usually quite good and strong. Right, so duration over 3 minutes, seeing that their eyes are closed even though it's been more than 3 minutes and it's a peak on the seizure. If they have asynchronous movements, if they don't, despite this long seizure, don't have lateral tongue bias and they don't have Babinski's and they don't have post-ictal phase. And once during their seizure, if they do not, if you can grab their hand, talk to them, and you can get some kind of voluntary response, such as eyes looking at you, then it's highly likely that this is a dissociative seizure. You should tell the patient this, even though you might do an epileptic workup. If it's the first time, then you should entertain the idea with a non-stigmatic composure that this may be a subconscious phenomenon called dissociative seizures, as well as it could be epileptic seizures, and that you should work out both things. All right, that's all for the extra bit here. See you guys. Bye.